It is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying the infraclavicular block. This block forms the mainstay of single injection regional anesthesia for hand, wrist, arm, and elbow surgery. This block is performed at the level of the cords of the brachial plexus. It is easy to perform, has a short onset time, and covers all the nerves distal to the shoulder joint. Most local anesthetic agents and combinations have been used for this block. The choice of this author is 15 to 40 milliliters of ropivacaine, 0.5 to 0.75%, of which 10 to 25 milliliters is injected onto the most appropriate cord, and the remainder on at least one of the other cords. Adding buprenorphine to the mixture triples the duration of action of the block, but if a long-acting block is required, it is best to place a continuous nerve block. All the neurotomes distal to the shoulder joints are typically incorporated in this block, and unless the suprascapular nerve is specifically blocked separately, this block is not suitable for shoulder surgery. The width of the patient's thumb is 1 sun, which is 2.5 centimeters in the case of this patient. A point that is 1 sun medial and 1 sun caudad from the midpoint of the coracoid process marks the point of needle entry if the pericoracoid technique is used. The dotted line indicates the midline of the clavicle, and a point 1 sun caudad at this line marks the point of needle entry in the VIP, or vertical infraclavicular plexus block technique, which is popular in Europe. The patient is in the supine position with the hand placed on the abdomen. The superior approach is, however, fast becoming very popular. Following skin preparation, the skin and subcutaneous tissue is anesthetized with local anesthetic agent. The stimulating needle, attached to a nerve stimulator set at a current output of 1 to 2 milliamps, 2 Hz, and a pulse width of 200 to 300 microseconds, is aimed directly posterior. A distinct give can be felt as the fascia layers of the major pectoral muscle are encountered and penetrated. The first nerve encountered here is the lateral pectoral nerve, which causes major pectoral muscle contractions. The needle is advanced, and the musculocutaneous nerve, which in this case is already separated from the lateral cord of the brachial plexus, is encountered. This causes unmistakable biceps contractions without hand flexion or pronation. Flexion of the fingers and ulnar deviation at the wrist indicates medial cord stimulation. The pinky moves medial. Pronation and hand flexion would indicate lateral cord stimulation. The pinky moves lateral, and extension of the fingers, the pinky moves posterior, would indicate posterior cord stimulation. The fifth digit or pinky thus moves towards the cord that is being stimulated. The current of the nerve stimulator is turned down until a brisk motor response can still be observed at 0.3 to 0.5 milliamps. Brisk motor twitches at an output of less than 0.2 milliamps may indicate intraneural placement. While keeping the needle steady and observing the motor response, local anesthetic agent is injected. The motor response stops immediately upon injection. This constitutes a positive Raj test and is an indication that the block will be successful. Any solution that conducts electricity, such as normal saline, will disperse the current density and will cause a cessation of the motor response if the needle tip is in the same fascial plane as the nerve. The other cords of the brachial plexus can now be sought and blocked if it is appropriate.